Good morning, good afternoon, and good evening. Welcome all of you to this live program with Orthopedic Principles. Today, our guest of honor is Dr. Patrick Dinard from Oregon, United States. Dr. Dinard is a shoulder specialist at the Oregon Shoulder Institute and director of the Oregon Shoulder Fellowship. After earning his medical degree from Dartmouth College, Dr. Dinard completed his residency at the Oregon Health and Science University. He then completed fellowships in advanced shoulder arthroscopy and shoulder replacement in San Antonio, Texas, and Lyon, France, respectively. Dr. Dinard is an instructor at the Oregon Health and Science University and continues to participate in research, presenting this nationally, internationally, and also instructing other orthopedic surgeons at courses on the shoulder. He's a co-author of textbook on shoulder surgery, The Cowboy's Companion, a trail guide for arthroscopic shoulder surgeon, along with Dr. Stephen Bankart. He has published 2 textbooks on shoulder arthroscopy, over 30 book chapters, and approximately 200 peer-reviewed publications. So today is my great honor to introduce you to Dr. Patrick Dinard from Oregon, United States. Over to you, Patrick.
Great. Well, it's an honor to be here. Thanks for having me. Over the next 20 to 30 minutes, I want to go over my approach to labral repair and really get into remplissage and why we are using that in an increasing percentage of our patients. So I think technology, first off, really changes how we do things. This little device here or other handheld devices have really changed our lives from a work standpoint. And I think that you're seeing that as well in what we are doing now with the scope. And I think when it comes to talking about labral repair in particular, previously knots were really the gold standard of what we were doing, but I don't think that's really the gold standard anymore. I think technology has really changed how we do things. I'm going to share with you kind of why I think that. First of all, there's a couple of ways you can approach this. Knotless options, as you know, you really have 2 ways to go about this. One is the suture first, anchor second. The second now, which are newer anchors that are now available, are anchor first, followed by tensioning the construct within the anchor itself. And I'll share with you why I think those are have some potential benefits. But what's my rationale? I've stopped using knots in 100% of my labral repairs, and I'll share with you why I do that. One, and I try to make everything that I do based on the evidence that's out there. And one is the biomechanical strength, which has shown equivalence. Really, the big factor is that you have improved reliability. And the second big factor is no knot migration or impingement. Also, I think you have some decreased incidence of iatrogenic injury, decreased bone removal, especially if you're using small anchors, and there's clinical support for these techniques. And then there is the operative time aspect, which I think is good for the patient and the surgeon. But the two biggest things I think are the reliability and the knot migration. So biomechanically, there's several studies that have looked at this. This is one of those studies out of Rush. They compared knotted versus knotless anchors, and essentially, as you see here, found no difference in load to failure, and others have found the same. I talked about reliability. This was an interesting study that Brian Hanipsiak did at Arthrex in Florida. And what they did is they brought in consultant surgeons who were there for a large meeting, and they asked the surgeons to tie knots. And they compared how the surgeons did amongst themselves and looked at the variability between the surgeons, and then they looked at the variability between the knots. And essentially, what you can see here is there's a wide variability in how well surgeons tie knots, and that's even in the hands of the so-called experts that are there at this type of meeting. Cohen Videx took this one step further. In Germany, he repeated the same study where he looked at, but he also added in knotless techniques. And I published this work with him, and what we found was that when we compared knotted constructs, yes, there was high variability, but if we looked at knotless constructs, the variability decreased substantially. So you can see on the lower left of these graphs are the tight clusters. Sorry, on the upper right, you see the tighter cluster where you have the knotless constructs compared to the knotted where there was wide variability, and many of those fell below what we would consider acceptable parameters for loop security of a construct. So conclusion was that knotless constructs are more reliable. Knot migration is a big issue as well. This is a classic study by Kim, the cadaveric study, and they looked at knots and they cycled the cadavers, and they found that the knots displaced medially by an average of 1 millimeter, and they typically tended to migrate toward the glenoid in the labral scenario. In 40% of the cases, the inferior knots in this series loosened. And this is a real issue. This is an example of a patient who came to me. Of course, we can criticize where the knots were placed here, but you can see that the knots have migrated medially. I would imagine they started laterally, and that's caused some abrasion of the humeral head, as you can see in that image. Iatrogenic injury, I think this is actually a phenomenon we don't really talk about a lot, but essentially what my belief here is the more times you're going in and out of the shoulder, especially if you're tying a static knot, you risk injury to the cartilage. And so if you're continuing to slide down with a knot pusher, I think the more times you do that, the more times you have a chance of hitting the humeral head. Now, what about the clinical outcomes? If you look at the studies and the clinical outcomes there, you see that really across the board, you see really no difference in functional outcomes. This is a study that looked at a small group, 45 patients compared to 42 patients, but no difference in functional outcome or recurrence rate, as you can see here. This is another study. They actually went out to 7 years, minimum 2-year follow-up, similar findings, no difference in recurrence or postoperative outcomes. And then time. We did a study where we looked at time in our patients from a large series from the Surgical Outcome System database. And we looked at all types of labral repair, but as you can see here, there was decreased operative time for knotless anchors. And it was only a few minutes per case, but if you add that up over several cases over a year, then it really translates into something that's really impacting your life. So I wouldn't take that as a single advantage, but if you can have the ability to have a similar outcome in terms of functional outcome and similar recurrence rate, but have decreased time, I think anybody would take that all day. So as I mentioned, again, there's two really techniques. There's suture first, and then there's anchor first. And I've really moved to the anchor first techniques. And within those, there's a couple of options. There's hard body, and then there's all soft anchors. All of these anchors rely on the similar mechanism you can see here, which is that there's a tensionable construct, at least with the anchors I use, within the body of the anchor itself. So you feed down a repair suture into the body of the anchor, and that tensions inside. But there's other companies that have different versions, and I think the biggest thing is just having knotless techniques. This is an example of a patient of mine showing a slap repair, but I just want to show you this video to illustrate how it works. So we have a right shoulder. There's a superior labral tear. This is a thrower. I have very uncommonly do I repair slap tears nowadays, but this is an example of indeed doing that in the case here. So we're placing a percutaneous port of Wilmington. We drill through. This is a 1/8 anchor. I use an all suture anchor. That anchor is going to go into place. Anytime I do a slap repair, if I'm placing anchors posterior biceps, I always go through a port of Wilmington portal. I'll shuttle through here with a curved lasso, retrieve that wire, and then this blue and white suture, or tiger blue, is the repair stitch. And then I like to really use mattress configuration. So I'll shuttle through the looped end of the shuttling suture. Then that will help me deliver the repair suture back down through the labrum, and then it will tension here, as you can see here. So especially in superior labrum, but even in anterior labrum, I really like mattress constructs. And there's your final construct. So this is the anchor that I typically use here, which is this Knotless Fiber Tak. This is available in 1.8 millimeter, 2.6 millimeter versions. I really like the 1.8 millimeter versions. I like to be as small as I can because I think there's some advantage to this. One is I can get multiple points of fixation. Two, I can use a curved guide because it's a soft anchor to really get low down into the glenoid. And that's something that's harder to do with a hard body anchor because you can't really use curved guides. And we'll talk about that. Advantage also is decreased bone removal. And that's why I've moved to using these small anchors. And then the last thing is that I like really placing my anchor first and tensioning up to that versus passing sutures and trying to figure out where my anchor needs to go. I find that to be harder to do. I like to really set my anchor because I'll get as low as I can and then shift up to that point. So increased fixation points. We know in rotator cuff and et cetera, the more fixation points you have, the more widely you distribute the load. And we also know that clinical evidence suggests that that's important in Bankart repairs. Pascal Below showed us this years ago, where he said that the patients who had 3 or more anchors had a lower risk of failure. Now, in some respects, that probably reflects the fact that they were getting low enough to put in 3 anchors or more, especially in a series like this where you're looking back, where you're using 3.5 millimeter anchors or above in size. But nonetheless, we can conclude from this study that if you have improved points of fixation, you have decreased risk of recurrence. And so that you can usually accomplish with using smaller anchors, because you can get multiple points along the glenoid. But of course, there's a balance here, because you want to avoid fracture when you have increased points of fixation. And how do you do that? Well, you can use smaller tunnels, like I said, using 1/8 anchors, or you want to be cognizant about altering your angles of insertion, regardless of what sort of knotless or knotted construct you're doing. So I think when we're talking about this, size really does matter. If you look on the left here, we got a 3 millimeter anchor tunnel versus here, I got a couple of 1.8 millimeter tunnels in just a sawbones model, but you can see that the size is quite different. And how does that relate to the volume relationship? If we look at a 3 millimeter anchor and then compare that to a 2.6, because of the radius squared equation, we have a 25% reduction in volume, but the 1/8, you have a 74% rather reduction in volume removed for the same length drilled. So that's quite substantial as you drop down in size because of that radius squared relationship. I spoke about this earlier, about what about the curved guides? We know from studies such as this by Itoi that if we use a curved guide, that you have a lower risk of perforation compared to straight guide. And in his study, they had only a perforation rate of 11% compared to 56%. You can see the outliers in the graph there. And this really makes sense if you sort of think about this. So if we pretend we're going to place anchors down here in a glenoid and the shoulder, what I would say we often do is we will get our first anchor as low as we can, but you're limited by the angle of approach. Second one, you maybe don't get quite at that same angle. And then I think a common thing that we don't talk about is people will put the third one in and they will put it in higher and they won't be thinking about coming in as flat. So what will happen is you get a convergence of drill tunnels. And then this can risk getting that postage stamp fracture postoperatively that we all want to avoid. So I would tell you what you want to try to do, of course, is get straight across the glenoid, which can be hard. And you can either do that by hitting a percutaneous portal or using a curved guide. And then especially as you come up higher, I would contend you would want to try to diverge from your previous tunnels to really lower that risk of iatrogenic fracture. And I think that's really facilitated by curved guides based on the evidence here. So I'll just illustrate that again. If this is the common thing, we take that straight drill in, then we go above, we don't get quite as low, and then we tend to do this with our top one. So conversely, if we use a curved guide, if we use that same sort of approach, but we have a 15-degree angle, we can alter how we're coming in and end up with this sort of type of construct, and especially at the top one, really going up and away. Now, what about cysts? I had a big concern about cysts initially when I started looking at soft anchors, and quite honestly, I was resistant to soft anchors initially because of those studies that looked at the canine model. But clinically, that has not really borne out. This is an extreme example, and I wouldn't advocate this, but I think it's interesting to look at this report just from the extent of how far you can go. So this is a study by Vic Agarwal, 18 patients, 2-year follow-up. He used a mean of 11.5 anchors per case. Now, I've never advocated 11.5 anchors per case, but nonetheless, he did 2-year postoperative MRIs, and in this series reported no cysts or tunnel widening. So even with a lot of anchors, he didn't see that be a problem. Larger studies have also reported that the incidence of cysts is very low. This is a couple of studies here comparing biocomposite anchors to all suture anchors, and you can see here that cyst formation in both groups is very low. Now, you do see some tunnel expansion in this series here with all suture anchors. However, if you're really starting from these, you see expansion in both aspects. And I think there's a difference if you're seeing some expansion from 1.8 millimeters to, say, 2.5 millimeters versus 3 millimeters to 4 millimeters, right? So there's a difference there where you end up. So now, when should we add remplissage in our patients? And I would tell you that my question really probably should be, when should we not add remplissage? Because more and more, the evidence is showing that remplissage reduces our rate of recurrence with minimal downside, at least based on our current evidence. So we know about the glenoid track. This was reported by Yamamoto and Atoi in 07. And in this series, they reported that the normal width of the glenoid was that the normal track was 83% of the glenoid width. And that had to relate, that was due to the translation of the rotator cuff, which is why it was 83%, because as your arm came up in external rotation, you had a slight translation where the cuff started to engage the glenoid. And they said in their classic paper here that you must take into account glenoid bone loss, right? So they said the Hill-Sachs lesion has a risk of engagement if it extends over that median margin. And then subsequently, and then later, we had classification of on-track and off-track lesions, and DiGiacomo, Itoi, and Bankart proposed this model here, where they said you should predict the preoperative glenoid width based on CT scan or intraoperative measurement, times that by 83% minus the glenoid bone loss, and then you had your remaining track, and then from there, you looked at the width of the Hill-Sachs lesion and determined whether that was going to be within the track or off of the track. And they recommended that if you had bone loss less than 25% and you had an on-track lesion, you could do a Bankart repair. And if you had bone loss less than 25%, but an off-track lesion, you needed to do a remplissage. Now, the problem with this is it's a really good way to really categorize patients, but it doesn't necessarily take into soft tissue instability or soft tissue laxity and the activity of the patient. But we'll go into, does this glenoid track work? And yes, if you look back at Bankart repairs retrospectively, as in a study by J.T. Tokish, where they looked at MRIs, you do see a higher risk of recurrence in patients that are off track. When they looked at their series, off track patients, now they only had 8, had a 75% risk of dislocation if they did an isolated Bankart repair. And this is in military patients. And they said that you had some pretty good sensitivity here. But I'll go into some data that we have subsequently that shows that maybe these results aren't quite as good as we think. So how does remplissage work, though? I think that's important to think about that concept, because that may have some implications for down the line that we don't quite know about. This is a study that I did with Rob Hartzler, Steve Bankart, and Ty Lee. Biomechanical evaluation, we created a 15% glenoid bone loss model. And then we created 2 Hill-Sachs lesions. Now, they were essentially on track or off track based on making these very large lesions. And what we found is that if the lesion was on track, Bankart repair restored stability in the cadaveric model. Okay. If they were off track, we had engagement in 100% of cases at the end range of motion with Bankart alone, and all cases were prevented with the addition of remplissage. Now, remember, in a biomechanical model, what you really don't have good variability in clinical in tissue laxity, and it's especially hard to create that model because you don't have that traumatic event that creates a stretching of the capsule. But nonetheless, we found that you had prevention of engagement with remplissage in these patients. And this is some of the data looking at, and you can see that translation, if you look over the far right, was decreasing substantially with adding remplissage. However, how does that happen? Well, really what it's doing is it's shifting the head posteriorly, and I didn't show that data here, but it's shifting posteriorly, and it's causing increased stiffness. Now, currently, we have not seen that impacts clinical outcomes, right? We have data out several years now. Now, is it possible down the line that we find that this consequential posterior translation and stiffness leads to a new problem that we'll identify? I can't tell you, but currently, based on our evidence, we don't see anything occurring clinically. But I just want you to recall this so that if, as a caveat, what I'm saying, that is something we need to watch down the line. So let's talk about the results. Well, how are we doing with Bankart repairs? This is a recent series. So I've showed this study because, this is a recent series representing modern techniques post 2010 in this series. And that's important because at this point in time, you are identifying patients that have bone loss. We know that bone loss is a risk for recurrence, but nonetheless, in this series of 100 patients, they had a 22% rate of recurrence. And especially in younger patients, you can see that risk was higher. So even with modern techniques, with an isolated Bankart repair, we're still having a failure rate in this series of 1 in 5. And other centers have found similar results. Another study by Peter Domos and Andrew Wallace. Now they compared Bankart isolated to Bankart with Remplissage. So what happened there? And as you can see on the group on the left, and this was about 30 patients, I believe, in each group. But when they had Remplissage to these patients who were non-engaging Hill-Sachs lesions, so smaller Hill-Sachs lesions even, they didn't quantify bone loss well, but non-engaging lesions, they only had a 5% rate of recurrence compared to 30% with isolated Bankart repair in these patients, so big differences. This is a paper that we just submitted where we looked at patients from myself, Pablo Narbona in Argentina, and Alex Laterman in Switzerland, as well as Johannes Barth in France. And we compared 75 Bankart patients to 48 Bankart plus Remplissage patients. And the key thing here is we looked at patients with less than 15% glenoid bone loss. So these are patients that from the most part, you'd say, okay, they have subcritical bone loss and they had a low rate of off-track lesions. You can see they're pretty active, but not all of them were overhead athletes. About 2/3 of them were active patients. Really no difference in functional outcome, but what you see here is a difference in recurrent dislocation, even in patients with subcritical bone loss. So this didn't reach statistical significance because we weren't powered enough to show a difference. But nonetheless, I think when you have a rate of 9% to 4 times less than that with Bankart Remplissage, I, after having this experience, have to ask myself, especially if I have a young active patient, when should I not add Remplissage regardless of the whether or not the lesion is on track or off track? This one was just accepted. Here we actually compared Bankart Remplissage to Latarjet. Larger series here, 188 patients compared to 70 Bankart Remplissages because we took all comers. Interestingly, as you can see here, glenoid bone loss was actually a little bit higher in the Bankart Remplissage group. Small differences, but a little bit higher. And outcomes, really no difference in outcomes, some slight difference in external rotation, but we really didn't see dramatic loss in external rotation 4 degrees in the Bankart Remplissage group. Some people have talked about that, but few studies have really borne that out. Probably the difference in improvement in external rotation with the Latarjet group, I think, was just how it was measured, but that was really the only difference there. Now you can see here in terms of the results, the return to sport was better in the Bankart Remplissage group. You see 91.5% of overhead or contact athletes compared to 73% with Latarjet. And you can see dislocation, no difference. But look at the complication rate. You can see the complication rate was much, much higher. And I think this is one of the big things with Latarjet compared to Remplissage, and authors have had similar findings. This is a systematic review looking at this. And you see here that the risk of, and this is comparing Remplissage to Latarjet, the risk of complications was 7 times higher based on multiple studies with Latarjet compared to Bankart and Remplissage. So it appears to be very safe and very effective. Now, we took that one step further, and we had a small cohort, and we're working on publishing this now, but we actually wanted to ask the question, okay, Remplissage is working very well, and maybe we should consider lowering our indication to use it more commonly in patients who have less degrees of bone loss. But what about the patients with high degrees of bone loss? Because there's some people out there that will say, well, I really don't want to do Latarjet. I want to avoid that complication rate. Now I want to try Remplissage for even substantial degrees of bone loss. So it's a small series here of patients, but we looked at 25 Latarjets compared to 22 Bankarts or Remplissage in patients with greater than 15% glenoid bone loss, because we wanted to look at what many people would consider critical bone loss. And you can see the average glenoid bone loss is actually 25% in both groups. And when you look here at our results, we actually had no difference in real dislocation, no dislocation in either group. And again, we had a couple of complications in the Latarjet group. Now, I would not at this point advocate that you can use Remplissage for everybody. Certainly, if you have somebody with a large degree of bone loss, especially a younger patient, I would still advocate for a Latarjet or arthroscopic glenoid reconstruction in those patients. But I think if you have a lower demand patient, you can probably see you could stretch those indications and consider remplissage to lower the risk of complication. So now let's talk about technique to wrap this up. Again, we have knotted or knotless techniques. A traditional technique is to place 2 anchors through the posterior capsule and rotator cuff, and then go up into the subacromial space and tie that. Most of the time in years past, we would take those 2 sutures from 2 sets of anchors and tie those in a double pulley technique. Again, like I've done with labral repair, I've really gone to knotless technology. This is a study here that done by Rob Hartzler and Steve Bankart, where they compared that double pulley technique to using knotless anchors where they interlink the 2 anchors. And as you can see, they found higher load to clinical failure and a higher yield load in the knotless group. So this is my technique. And so what I really over the years have tried to do is try to find a way to avoid going into the subacromial space, because that's the real pain with remplissage. And I think, quite honestly, if we're really being critical of ourselves, if we have that patient who's on the border, that's oftentimes where we may say, well, I don't think that patient really needs it, because you don't want to go into the subacromial space and add 30 minutes to the procedure. So what I started doing is doing this in a percutaneous manner. I have my posterior viewing portal, or I say posterior cannula on the left. It's my standard cannula. I always scope lateral and I view from ASL. And then at the beginning of the case, once I determine that I'm going to do a remplissage, I then will place a cannula through the deltoid till it's just above the posterior capsule. And that's actually quite easy to see, as I'll show you in a subsequent video. You can really get a pretty clear sense that you're through the muscle and down just above the posterior capsule and rotator cuff. Then through that cannula, when I'm holding it in place, I will place an anchor. I'll go inferior first, and then I will place a superior anchor second. I place the inferior one first because you need to see the inferior one first, and then I'll place my second one. And then I'll do both of those through the same cannula. So now I have both sets of knotless sutures just through the capsule. And if I keep that cannula in place, I have my track all the way down. All I have to do is use a knotless mechanism to link those. And I'll do that after I do my Bankart repair. So this video will show you how I do that. This is an example of a left shoulder here. You see, now I orient beach chair, but I scope lateral. This patient has a large Hill-Sachs lesion. So I first establish an ASL portal. I'll go a little bit more medial than my normal ASL portal, and I'll place a 825 threaded cannula. I want to go more medial for that ASL portal, about 45 degrees angle of approach, so I can get to the superior labrum. And then I will view from my ASL portal, and I will assess glenoid bone loss. You can see this patient has a small amount of glenoid bone loss anteriorly. I like those self-retaining cannulas posteriorly and anteriorly to really hold the soft tissue. That's just a technical thing. Then I'll measure the Hill-Sachs interval. But again, I really, have lowered my threshold. I'm showing you that how we measure it, but quite honestly, I really have a very, very low threshold, and it's only the rare patient that I do not do a remplissage in now. For instance, a patient over the age of 30. I'll prep the defect through that posterior portal. Now I want to place in the low accessory posterior portal. So I'll first use a spinal needle, and I'll say, okay, where is the center of the defect? And I want to come straight in line to the Hill-Sachs defect. Then I place my cannula. Once I've made a small skin incision, I take that cannula and I just clear out the space by moving the cannula around. There you see in the outside view, I'm through the deltoid, but I'm just above that capsule. And you can see, even in some patients with poor tissue quality, you can see that the edge of the cannula even, so you really get a good sense that you're in. Then from there, now that I'm resting right above the soft tissue, now I just need to percutaneously go through, and I'll place my 1/8 anchor at the bottom first. To be, to be critical here, I perhaps could have gone more lateral with this anchor because I want to be up to the edge. However, I also try to be cognizant of how much I'm being over tensioning. So a little bit of that part is the feel. Second one, I go straight through, just protecting those sutures. The cannula is down again. This way I don't have to do any extra shuttling. Then my 1/8 anchor goes into place. Now I will then protect those sutures once these both these anchors are in. So I'll put little snaps on those or hemostats so that I mark the sutures. And I don't want to tension it down yet, because what I want to do is I want to be able to go and still have freedom of working space to do my Bankart repair. Now, some people will do the Bankart repair, then go and do the remplissage. I really would not advocate that, because you get soft tissue swelling back there. I don't think you get the visualization. So I always will place my anchors first for remplissage and then go do my Bankart repair. So in this case, there was a small little area that needed to be cleaned off the glenoid, and I'll insert my anchors. Here I'm using the straight guide. This was prior to me having the curved guide. In this case, I'm using a percutaneous low anterior portal to get low, but most of the time with that curved guide, I don't need to do that. And then I'll demonstrate, in this case, simple sutures, but really, I've really gone to using mattress sutures, especially inferiorly, because I didn't get into this, but you do see with the knotless tensionable constructs that the mattress constructs hold up a little bit even better than the simple constructs. And then once my Bankart repair is done, then I just need to go and link those two anchors down outside the shoulder. And that's pretty simple, as you can see here. Once I'm just doing that, I'm just pulling that down, and I'll oscillate back and forth. And then here you see my defect is inset. And it's about filling, but it's really biomechanically, it's about providing that posterior translation of the humeral head. So my top tips for remplissage really are: place the remplissage anchors first. That accessory portal, make sure that it's in line with the posterior capsule, as I showed you here. So it's usually just lateral to your low posterior lateral portal, but go straight in line with the capsule and find the center of the defect. And then other than that, once you place your cannula, just place a hemostat over those sutures to separate those, so then you know which is which. And I'll typically try to place a hemostat in different positions, so I know which one's the low portal or the low anchor, and which one's the top one. But in summary, I think knotless technologies really, I think, should be your gold standard for labral treatment in general. Tensional constructs are just the latest evolution that I happen to like, but I think all of them work. But just the nice thing with the tensionables, especially with remplissage, it really facilitates that procedure. And I think remplissage, you should consider on the Glenoid Track, but consider using it more liberally, especially in patients at high risk, and really ask yourself the question, based on the evidence now, what is the downside to remplissage? And knowing that right now we have little evidence of downside, when should you really not use it? And I think if you start looking at it that way, you will find less and less reasons to do an isolated Bankart repair. So I'll stop there, and thank you for listening, and I'll see if there's any questions.
Thank you, Patrick, for that brilliant talk. Very much cutting edge. Couple of questions from our side. Patrick, have you seen extension of the labral tear beyond the 6 o'clock towards 7 o'clock? And that is one of the reasons for recurrence?
Yes, I think it occurs. I mean, I definitely see that in my patients. But I think what you're getting at is some people would say, well, there was this thought a few years ago that a posterior anchor would help reduce recurrence. And I think what was actually happening is you're just tensioning the posterior capsule, tightening up, and giving a little bit of restraint to the head posterior, because you're just tensioning the posterior inferior. So remplissage is essentially doing that, but doing that more effectively, because you're providing greater posterior restraint to the head. And so for me, I don't place that low posterior anchor unless the tear goes there. If the tear goes back, absolutely, I will put an anchor there. But if it's just a little frayed, I just do my Bankart repair anteriorly and do my remplissage and call it a day.
Thank you, Patrick, for that. And from your talk, you mentioned that if it's an on-track lesion, you can go with the Bankart repair, and if it's off-track, Bankart plus remplissage, right?
Well, I would say 5 years ago, I looked at it like that. Yes. Currently, I consider the Glenoid Track, but I really try to ask myself, when should I not add the Remplissage? Because I just see very little downside. So numbers wise, for me, 75 to 90% of the time, I will be doing a Remplissage. Okay. And for me to say that I will not do a Remplissage, they have to be on track. It can't be close. And they have to be a patient that's lower demand. They're typically over the age of 30. But honestly, if I have a 20-year-old young man who's going to be at very high risk of recurrence, regardless, if he has a glenoid track of 20 millimeters and his Hill Sachs is 15, well, he's really active. He's probably a little more lax. That equation does not account for laxity. I'll add my Remplissage.
Thank you, Patrick, for that. And what do you think is the role for an open procedure? For example, the open capsular shift that is very popular at one point of time. Do you still think that there's a role for that?
Not in my hands. And honestly, some of that is probably because I didn't learn that well in my training. I mean, honestly, I never saw a well done Bankart in my residency training. I think it's a lost art. I think that's part of it. I also like to think that I'm viewing ASL and I get very, very low and can see very well. I think with an open Bankart, you probably get a little more. I don't think there's anything technically I could do, but you probably get a more scarring. So could you get some small differences? Yes, maybe. But for me, when I can do arthroscopically, when I can add a Remplissage in these patients, I don't have a lot of utility for it.
Thank you, Patrick. And at one point of time, we talked a lot about iliacrest bone grafting, allograft, until Remplissage really took off. So do you think there's still some role for those procedures, ICBG or even adding as allograft?
Yes, I really do. I think, especially if you have an easier technique to do it arthroscopically. I think arthroscopic Latarjet has a lot of limitations, but I think as the techniques for a free bone block improve, and Ivan Wong has showed this, that I think you'll see a movement to try to make these reconstructions as anatomic as possible with a free bone block. And actually, we just had a study accepted where it was pretty interesting. We looked at patients or cadavers that had I believe it was a 20% glenoid bone loss model, and we compared Latarjet to free bone block, no difference, actually biomechanically. But interestingly, we added Remplissage to the free bone block, and we found that was the best in terms of reducing dislocation. So maybe as you get into, you're now having a easier technique to do arthroscopically, you're doing a bone graft and you're doing Remplissage at the same time. That's rare, but I think there are those patients out there who continue to have problems with Latarjet.
Thank you, Patrick. Just one last question before I end the session. What is your approach to a multi-directional instability? A slightly different part of the spectrum. So how do you treat that?
I mean, first of all, I try to be as conservative as I can, but so it's not a common procedure for me. But if a patient is truly has symptomatic multidirectional instability, and I feel like they've failed 6 months of conservative treatment, then I will offer them a capsular shift. What I like to do is I like to use the small anchors. And what I will do is I will view from ASL, and I like to work simultaneously up. I will typically do 3 to 4 anchors anteriorly and posteriorly, placing anterior, inferior, posterior, inferior. I'll put both anchors in, and then I'll pass both, and I'll tension both, and I'll work up. So typically I'll place an anchor at 5 o'clock and 7 o'clock, and then just work up as I go along, 8 o'clock and 4 o'clock and subsequently. I think I can actually help a lot of those patients. I think we got a little bit on the far spectrum of you never want to operate, but I still always be conservative first, and I make sure that there's good buy-in from the patient, that I really think there's not other issues going on, secondary gain, et cetera. But if you have that properly selected patient, I think they can do very well.
Thank you, Patrick. Patrick, I think that's all the questions that we have for this session. Thank you for this fantastic lecture.
Wonderful.
I'm sure this is going to benefit a lot of people all over the world. Thank you so much for